Hi, my name is Andrea Venesky. I am the trauma therapist at the Children's Advocacy Center in Montrose. Our full name is the Children's Center of Susquehanna, Wyoming counties. We serve children who have alleged some sort of abuse, maltreatment, neglect. We provide forensic interviews, which are specialized interviews for these children who have made these allegations, forensic medical exams for those kids after they have had their interviews completed. We do some outreach within the communities. We go to the schools and provide additional information to assist with different things. And then I am here providing therapy to children that are referred. Um, so, like I said, I am the trauma therapist here. I have been here since June of 2017. Since I've come to the CAC, I have obtained my professional license. So I am a licensed professional counselor in the state of Pennsylvania. I am also a nationally certified counselor. And I am also certified in trauma focused cognitive behavior therapy, and I am trained in parent child interaction therapy. And I'll get into those two models a little bit later, talk about them in a little bit more in depth. Um, so, again, I work with children who have alleged some sort of trauma. Um, Most of the children that I work with have alleged some sexual abuse, physical abuse, witnessed to domestic violence, victims of homicide, or excuse me, their parents have been killed by means of homicide. Um, I have dealt with some children who have been drug endangered and they lost their parents due to overdose. Um, Children who have been bullied really bad that has resulted in some serious mental illness from that. Um, I can't think of anything else off the top of my head. But those are the big ones that I do deal with up here in Susquehanna and Wyoming counties. Um, some kids come into the office and see me, and then I also do go to a couple of school districts and see children that don't have the means to come to our office in Montrose due to transportation issues, things like that. Um, I primarily work with children from the age of 5 or so up to the age of 18 that they can be seen here at the CAC. My youngest right now is 4, and she is being seen with the PCIT therapy model. Um, the therapy models that I work with, so again, I'm certified in trauma focused cognitive behavioral therapy. Um, that therapy model is designed for children between the ages of 17 and 18. It is like the therapy model is named, it is trauma focused. So every time that the child comes in, we're talking about their trauma. There's various pieces of the therapy model um, that we work and we go through. There's a psychoeducation piece, there's a relaxation piece, there's at the end there's a desensitization piece. It's very written out as to how to provide the therapy model. It is evidence based, so there's lots and lots and lots of research behind it showing how effective it is. It is one of the top models that is used for trauma with children. There are various adaptations for TFCBT. There's some for children, young adults between 18 and 21. They're coming out with some for children that have autism. Um, there's complex TFCBT, so that would be children who have complex traumas. So, traumas that have occurred more than once over a longer period of time, things like that. Um, the therapy model is designed to last between 12 and 18 sessions. It's not supposed to be long lived. It's supposed to be a shorter time period. And again, there's lots and lots of evidence that shows that this therapy model is extremely effective. Due to COVID, I have been seeing some kids through telehealth. And again, they have done research with TFCBT down at the University of South Carolina um, to see if TFCBT is still effective through telehealth, and also to see if TFCBT is still effective at schools. The big piece of TFCBT is that there's a very large parent caregiver portion of it, because when a child has experienced trauma, when they have gone through a traumatic event, it will in effect affect the other members in the household. So the parent or slash caregiver, if they're the non-offending parent, other children in the home, it obviously can affect them too, indirectly or directly if they were also a victim. Um, so the caregiver parent piece is a big piece, as they will go through the stages of TFCBT with the child as well. Um, I see this as a great benefit to the therapy model, because some parents don't know what to say to the kids after they've disclosed some sort of traumatic event. Um, it just can bring a piece of calm to the parent to know that they're also not alone, that this happens to um, unfortunately, it happens to a great deal of children in our communities, even small communities like Susquehanna, Wyoming counties. It's still a very high prevalence rate. Um, so the parent caregiver piece is a very large piece of the therapy model. When I see children in school, I'm in contact with their parent via email, via phone calls, to let them know what we're working on, what the child's homework is, if they have any questions, etc. Um, and sometimes it's not enough for the kiddos, and they have to still be seen in the office, because it's not good to sometimes dig up all of this stuff and then send the kid back to class. Sometimes it's just too much for the kiddo, and that's completely understandable. Um, so that is pretty much all I can think of right now for TFCBT. There is also assessments that I do for TFCBT. It's the TSCC, which stands for the Trauma Symptom Checklist, and that for children, and that is for older kids. And then there is a younger assessment as well. That is, they're both done at the beginning and the end of the treatment periods to show if a child's made any progress or not. And I'm at 100% where they have made progress when they have successfully completed TFCBT. Um, the other assessment is the TSY CC, which is for the younger children. That one is to be filled out by a parent caregiver. And then the other one can be filled out by the child if they feel comfortable doing it, if they're able to do it. I've never had a kid that's not been able to do it. Sometimes it's 54 different symptoms, behaviors, things like that, that they just rate on a scale of how often they experience those various symptoms. So sometimes or some of the different things listed on that one is like scared of the dark, um, being afraid of women, being afraid of men, how often they feel that way. And then how the assessment works is that it breaks it down under different criteria, different symptoms, things like that. It'll say, this symptom falls under depression. This symptom falls under anxiety. This symptom falls under PTSD. This symptom falls under dissociative. Um, and then that will show me where the child needs the most help. Maybe they need the most help with their anxiety. They're really, 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 really anxious. So that's the piece that we're going to work on more than these other things that they're not having issues with. So that's a really great assessment tool to use for the children that I've been working with. And they always find it fascinating, like when I rip it off and it's a carbon copy and they can see the chart and they're like, oh my gosh, I do feel more nervous than I do feel depressed. So it's funny to see their reaction sometimes. So then the second therapy model that I work with here at the CAC is parent-child interaction therapy. This therapy model is designed for children between the ages of 2.5 and 7. And again, there are different adaptations that can be made for kids that are a little bit older. PCIT is in 2 phases. The first phase is called CDI, child-directed interaction, and this is what we call the warm and fuzzy period. So this during this piece, the parent caregiver is going to be building their relationship with their child, getting their child to trust them, getting the connectedness better, beginning to bond better with their child. During this piece, it's a form of play therapy. So essentially, the first session they come in, it's called the teach session. So I sit here and I go over all the different things that the parents are going to do when they're in session and all the things that the parent is going to try to avoid during session. So like things that they do, they're called behavior descriptions, there's reflections, there's labeled phrases, and things that they try to avoid are questions, commands, and criticisms while they're in there with the kiddo during their session time. And then they have to also work on this at home. It's homework that they do once a day. Um, and so that's the first piece where the child gets more comfortable. They bond better with their parent caregiver. And then the second piece is PDI, or parent directed interaction. And this is the discipline phase. So this is when we introduce timeout. The first phase has to be done first before the second phase has to or is done, is started, because if we go straight to PDI, then it's probably not too much different than what the parent is doing at home. Many parents utilize timeout as a discipline for younger children. So if they're just going home and they're starting PDI right off the bat, they're not doing that warm and fuzzy phase, then it's not any different. They have to build the relationship in order for the child to trust them, to feel safer with them, to feel that love again from that parent that can oftentimes become very strained with children who have behavior problems. And I'm sorry I skipped that. PCIT is for children who have behavior problems, ADHD symptoms, um, fighting, hitting with their siblings, our parents, or friends their age. It's made to address those specific behavior symptoms. The assessment tool that I use for PCIT is called the ECB, and it is, I don't know, maybe 50, 55, I forget the exact number, of different symptoms that the parent has to just look at the symptom. And there's a rating scale of 1 to 7. 1 is none, 7 is always. And so they just go through that. They circle whichever one. So poor table manners, never. Um, Takes his time getting dressed, always. And then there's a second piece to it. Is this a problem for you? Yes or no? So maybe the parent doesn't care that their child takes forever to get ready because they don't really have anywhere to go. Maybe the kiddo isn't in school yet, the parent's not working. So it's like, well, it's not really that big of a deal if he, putzes around forever and doesn't get dressed because, whatever. It's not something that I really care about. So then they would circle no, and that would be something that we wouldn't work on. Um, and so with PCIT, I do that ECB, that assessment, every single session, because what we're looking for with PCIT is for that number to go down. So I go through the whole ECB, that whole assessment. I add up all the different numbers and get their score each week. And if they're doing their homework, if they're coming to session, if they're doing what they're supposed to do, theoretically that number should be going down. Sometimes it doesn't. Sometimes there's other pieces involved. Maybe the parent only has the kiddo half of the week, or they have the kiddo 1 week and not the next week. Maybe they have the child all the time, but only one parent is doing the therapy, not the other parent. So there just can be barriers in that aspect. PCIT is also designed to be short-lived, so it's designed to last between 12 and 16 weeks. Sometimes it goes more. I've seen it in as many as 37 and as few as 12. Again, it depends on how quickly the parents are catching on, how well they're doing with their skills, their do skills that I talked about earlier, and their don't skills, how often they come to session, how often they're completing homework at home. And again, those other barriers that I just talked about. Um, so so then they have to master CDI, we call it. So they have to have a certain number of various skills that they use in a timed setting. Um, and then we move on to PDI, which is again the discipline phase of PCIT. And that's where we introduce timeout. And sometimes it goes okay. So I've had kiddos that have come in and have never run a timeout chair. And then I have kiddos that have come in that I've been in session with them for 2.5 hours because they're constantly they're in the timeout chair, they get out, they get in, they get out. And they have to stay in that timeout chair. They can't hop on and hop off. They have to stay on that timeout chair. Um, and then once we work our way through the PCIT curriculum, at the end, they have to have, so that ECB that I use for the assessment, their score has to be below 114, and they have to be comfortable with using the skills at home in the community for them to graduate. And then we have graduation session, and then there's a follow-up a month later to see how they're doing, to see how their skills are, to see how the child's behaviors are. And I encourage parents to continue doing CDI at home, to continue being consistent with the timeout at home, because obviously it worked. You were able to graduate PCIT. So if you continue doing the stuff that you're doing, you're going to continue having success with your child at home. So those are the two therapy models that I primarily use here in the office. Obviously, there are other trauma evidence-based therapy models for children that you can use. But those are the two that I'm certified in Tfcbt and I'm trained in PCIT. So those are the two models that I use here, and they are both evidence-based for trauma for children. So those are the two reasons why I use them here at the CAC. So that is what I do here in Montrose. If you would like more information, please reach out to us. My phone number is 570-823-5144, extension 372. I'd love to talk to you more, or if you think that you have a kiddo that you'd like to refer, we can chat about that. So thank you and have a good day.